It's been a little bit since we've published a core ultrasound image review. Ben Smith, Taryn Trott, and I were super busy putting together the content creation and ultrasound management course that we were able to debut March 15th and 16th live. If you were able to check it out, we're so happy to have had you there. And if not, we are actually offering the course on demand on our courses.coreultrasound.com website. So check it out there if you missed out. In this image review episode, we are going to talk about some OB stuff. We're going to talk about intrauterine pregnancies, ectopics, and how to tell the difference between the two. We're going to do a little bit of gallbladder discussion, which is always great. And then I'm going to talk a little bit more specifically about DVTs and some tips and tricks. The big one is to make sure that you are actually looking at a deep vein. Now, that seems weird. I mean, we're saying DVT. Obviously, we're measuring the deep vein, but I see it fairly frequently where a superficial vein will be compressed and the practitioner thinks that it is actually a deep vein. Big tip here is to make sure that when you see a vessel that you think is a deep vein, check and see that there's an artery right next to it. The deep veins almost invariably lie with deep arteries. So if you have a vein right next to an artery, more likely to be deep. If you have a vein by itself, less likely to be a deep vein. I spend a little bit of time talking about upper extremity DVTs and how you can use your point of care ultrasound to identify DVTs in the brachiocephalic, the superior vena cava, and the subclavian veins, which can be a little bit tricky, but there's some tricks for it. Check it out. Core Ultrasound Image Review, episode number 12. Now, what do you guys see here? What is going on?
Clot somewhere.
Okay, that is great. So, thank you for that. He's saying this is maybe a clot. And I think that maybe he's saying that because there is a circular structure here. And then we're seeing like an open kind of lumen right here with a little thingy in here. I can definitely understand how that could be a thing that you might think. What if I told you that this was not in a blood vessel?
Is that a baby?
It is a baby for sure. We have a endometrium up here. We have a gestational sac, and we got a little itty bitty baby right here. And I even see a little beady boy right there, right? Now, can somebody read my mind? I would like somebody to read my mind, please, and tell me why I have a hard time with this itself. Why this is inadequate from my point of view. Read my mind. Anybody have any questions? Or thoughts on that, I guess. Not questions, but thoughts.
You can't see the cervix or vagina.
Yeah, that's exactly right. So I don't know if this is in the uterus or not. It's definitely a gestational sac. There's definitely a fetus in there, but I don't know exactly where this is located. Now, the person who did this, I'm sure that they already identified that it was in the uterus, and they were doing this to try and get a better visualization of this very early IUP, and that's perfectly fine, but you need to see this first. You need to make sure that that gestational sac here is actually in line with this structure over here. Now, this here, this is the vaginal canal. The cervix is right there. And you have to make sure that you're seeing that in line with all of this. And that means that it is, in fact, in the uterus. Here's an example of an IUP, and we can see that right here. We have the vaginal stripe going right into the uterus, and then we can see a nice gestational sac right there. And just for a bit of trivia, this is actually my now 2-year-old's first ultrasound that we did. So that's Logan sitting right there in that little uterus. Here is a clip that we actually did. I think it was a few, maybe a month, maybe a few weeks ago. Now, we're seeing this, and let's assume that this was definitely in the uterus, because it is. That's not the point of this like kind of next section. It's really difficult for me to see the gestational sac, right? There's a couple things you can do to fix this. The first thing is I would drastically decrease the depth to about half. Remember, when you decrease the depth, you're not just like, zooming in. You're actually changing the resolution of the ultrasound machine, so the image itself will look a lot better. But before I talk about that, I need to talk about this right here. This is a pulse wave Doppler gate, which is how I see a lot of people often try and measure the fetal heart rate. I would highly suggest, if you are able to not use pulse wave Doppler, but instead to use M mode. The reason why is that although there's been no, as far as I know, reported harms associated with using pulse wave Doppler, the pulse wave Doppler actually does create a little more energy, or requires a little more energy to be sent out from the ultrasound transducer. If you have more energy sent out, there is more of a potential for harm. You always want to use the lowest dose of whatever it is that you're using to get the effect that you want. M mode is exactly the same as B mode. It's just interpreting the data differently. So if I see this, a pulse wave Doppler, I cringe a little bit because most of the time you can get the exact same data using less energy, and that is the M mode. So this is that image with less depth, and you can see that a little bit better of a resolution. And what you do is you throw the M mode cursor right over top of that to get a tracing that looks like this. And the way that you use the M mode is you see there's a 5 right here. This 5 corresponds with this 5 right here. So the fetus is right about 5. So I'm going to look here and I see this repeating pattern. There, 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 there. And you measure these out. Our machine has it averaged over 2. So that's where we get the heart rate here. Now I will tell you that if the fetus is less than or 5 centimeters or so or less, you can actually do a little bit of a trick. You can use a linear transducer on top of the abdomen, and it gives you a very high resolution image, very similar to what a transvaginal ultrasound will give you. You can see here that we're getting way good resolution of that gestational sac, way good resolution of that fetus in there. And then you throw that M mode cursor on there. It's at about 4 now because I'm pushing on the abdomen to try to get the probe a little bit closer. 4 is right there, and I can see a repeating pattern here, 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 here. And that's how we should check the fetal heart rate. Linear transducer works really well early in pregnancy, as long as you can get the probe to within about 5 centimeters of that fetus. All right, here's another case. Do you guys see that gestational sac? Did you guys see it? Right here. All right, I see a gestational sac. Does that mean I'm done? Do I just like move on, just call it IUP, discharge the patient? See it.
No, line it up with the vagina and the cervix.
Yes, exactly right. Now, what if so this was the first one. This is actually one that I saw. It was another physician was like, hey, I think this is gestational sac, but can you help me out with it? I went and got another image, and here is the uterus, you guys. It's right here. Going into the vaginal stripe. Do you guys see that gestational sac in the uterus? I sure don't. What do you guys think all of this is up here? See all this stuff all the way around?
Now it's clot. Now it's clot.
Nice. Yes, yes. This is definitely clot. We can see a little bit of actual free fluid, this hypoechoic stuff kind of there, maybe a little bit down here, a little bit up there. This is all clot. If we go back to this original one right here, this, go back. This right here is this gestational sac outside of the uterus, kind of within all of this stuff, which is all clot. Here is another patient here that presented with acute abdominal pain. You guys see this right here? What is this? What do we got here? It's a positive FAST in the right upper quadrant. And this is that patient's pelvic view. Now, this is a different patient from that previous one. Now, I see the uterus here, right there, going into the vaginal canal, and I see a bunch of clot with a little bit of free fluid down here. It's very important when you're looking at a patient with acute abdominal pain to not confuse clot for bowel. It's something that can happen if you're not paying attention to it. Right about here, that's the gestational sac on this other ectopic pregnancy. So be very careful on these. If you see clot, you see especially free fluid in the right upper quadrant with a positive pregnancy test, you don't need to get a radiology performed ultrasound. You don't need to get anything else. This patient needs to go to the OR with our OB/GYN colleagues. And these are situations in which they will, if you show them the image, they will say, okay, you're right, and they'll take them up. So don't hesitate on these patients with acute abdominal pain with suspected rupture ectopic. Don't hesitate to contact your local OBGYN physician. This is an interesting ectopic that I had in residency. So right here, you guys see the gestational sac here? I see it. It's good. Now I see the vaginal stripe. I see it right here. Right? So I'm seeing it in line with the vaginal stripe, but I will tell you that this is the first time that I ever saw a cornual ectopic pregnancy. This is the uterus. This is the uterine cavity where a IUP, a viable IUP, would be located. And you can see that this is actually outside. It's actually sitting in the meat of the fundus, and that's what a cornual ectopic pregnancy. So be careful with that. You want to make sure that you can identify the center of the uterus to see if that IUP is in there. Now here is one that I see probably once a year. It obviously happens all the time, but I see it like once a year and it confuses me. This is a patient with a positive pregnancy test with abdominal pain, maybe some light vaginal bleeding, and some abdominal pain. Does anybody have, and this is a transverse view, by the way. I have the bladder here. This is the uterus. This over here is an ovary. What do you guys think is going on here? Any thoughts?
A cyst and a pregnancy?
Okay, a cyst and a pregnancy. That's brilliant. Wilson's kind of on it. Now, what if I told you, Wilson, that this patient is on Clomid, which is a fertility drug? Yeah, is right. So this you have to be really careful with, because now I will tell you, you're totally right, Wilson. This is a ovarian cyst with a perfectly normal intrauterine pregnancy early. But be very careful. If you see what looks like 2 gestational sacs, make sure that you get an adequate history on your patient to see if there's any chance that this patient could have something called a heterotopic pregnancy, which is basically 1 gestational sac in the uterus and another gestational sac outside of the uterus. This specific case that I'm showing you right now, this is actually a corpus luteum cyst, which a corpus luteum cyst is something that is very common in the first trimester. Remember, the corpus luteum, before the placenta adequately forms, that's actually what's going to be supplying all the stuff to the early gestational sac and early fetus. So just be aware, early in pregnancy, no fertility treatments or no other risk factors for a heterotopic pregnancy. Very likely to be a corpus luteum cyst. Or alternatively, if they are somebody who's had in vitro fertilization, somebody that's had any kind of medication for fertility, be very aware that a heterotopic pregnancy can happen and that it can look like this.
Do you remember what the HCG level was for this patient? Not that like a single measurement makes a difference necessarily, but yeah. I mean, if it was super, super high, I think I'm worried about like some of the heterotopic issues that you mentioned before.
Yeah, so this particular patient had a perfectly adequate HCG for the level of pregnancy at which they were in. So it was normal. Now, one thing that I'll kind of dovetail off of that, if you have a patient with a high suspicion for an ectopic, don't let anybody tell you that the HCG is indicative of the presence or absence of an ectopic. You can have an ectopic pregnancy with an HCG of 0. Those can still bleed and your patients can still die. So if you have a suspicion of it, don't let the HCG dictate your ease of getting, or your, what's the word I'm looking for, Bronner? I can't think of it. The chance of you getting an imaging study if you think it's appropriate. And then one more thing, Forrest mentions, really good point, that part of probably what made this a good view, besides operator experience, of course, is the fact that the bladder was full. When the bladder is full, it helps the sound waves get to the uterus a lot easier. So definitely good idea when you're doing a transabdominal ultrasound to look at the uterus when the bladder is full, not like right after they pee. Josiah asked, any tips on seeing ovaries on transabdominal ultrasound? I can never see them. You and most everybody else, Josiah, it's very difficult to see the ovaries. I will tell you that for me, the 2 big things are the bladder being full, that helps a lot. Often a little bit of pressure helps too, like just pushing out a little bit harder on the transducer. The other thing too is for the pelvic views, I am mostly completely not a fan of a transverse view of the pelvis, especially for the FAST exam. However, if I'm looking specifically at ovaries, the transverse view is probably the most helpful, because you can see in this image here, you can see that this is the uterus, and you can see that this ovary is attached very easily to the uterus, just like an anatomy picture. So I'll look transverse and make sure that the bladder is full. But it's kind of like looking for appendicitis. Understand that it's a difficult examination for most people to do. So always a good idea to try, but don't be discouraged if you can't see that ovary. Great. Any other thoughts or questions on that? Sweet. Let's move on to, now we talk about this, but this is a very common complaint, the right upper quadrant pain. Does anybody have any thoughts on this gallbladder scan? What do we think? Normal, abnormal, good view, bad view? What do you think?
Big gallbladder.
A big gallbag. Now, do you see any stones in there at all? Any abnormalities? It's not a trick question.
Off at the neck, like right at the end.
Yeah, it's normal. I mean, it looks great. One thing here is you see this kind of black thing, this black kind of shadow looking thing right here. This is right at the neck, but I will tell you that this is normal. This is actually something that's called an edge artifact. Whenever you have a circular fluid-filled structure, technically this is cylindrical. This is the portal vein. You have a kind of tangential artifact of shadow that will come off of a curved structure like you see here. This is an edge artifact and it's not a stone. And the way that you can tell that it's not a stone is you can see that it's very well kind of attached to the wall here of this artery. You can actually sometimes see that coming off of the fundus of the gallbladder, or really any fluid-filled structure at all. This is a normal scan here. What about this little guy right here? What do you make of this? This is what a contracted gallbladder postprandial looks like. This is perfectly normal. Now, one thing I want to show you is this. You see how there's like kind of like an outer layer, an inner hypoechoic layer, and then another hyperechoic layer. You almost can see those three muscular layers right there. That's just the gallbladder wall, how it looks when it's flexed. Remember, every time that you eat, the gallbladder is going to flex its bile into the duodenum. Normal image here. Great job. All right. What do you guys see here? This is a pretty fun one. Big old stone. Now, if this patient presented with right upper quadrant pain, I would do this ultrasound and basically just call surgery, because this is a very large stone that's impacted in the neck. Now, one thing that I wanted to show you is that oftentimes you are going to see a stone that's just a pure kind of hyperechoic rim with massive shadowing underneath it. But you can see that with this stone, you can actually kind of see a little bit through it. You can actually see the whole thing, just not the outer rim. Stones are going to have different compositions of material. Some of them are going to have a little more calcium, which if they have a little more calcium in them, they're going to be a lot brighter of a rim, and you're not going to be able to see the actual stone itself. But others, like this one, might have a higher, more cholesterol component, in which case you might actually be able to see more of the circle of the stone. But in any case of a gallstone, you're going to see this posterior acoustic shadowing right here. So you see this shadow here? This is edge artifact from the gallbladder. Here's the edge. And then this shadowing here, this is coming from the center of that gallstone. So this is actual acoustic shadowing from the gallstone itself. Subtle difference there. What about this one right here? What do you guys see here? I'm going to pause it right on the most important frame, which is right here. You guys see that little guy in the neck? That is a gallstone. That is an obstructing gallstone right at the neck. And I'll go ahead and continue scanning this, and you can actually see that maybe right here, right there, there's actually a little bit of sludge even in that gallbladder. So we got gallbladder sludge, we got a stone right in the neck with some acoustic shadowing. This is what an obstructing gallstone looks like. This is a gallbladder that has a lot of science on it. And this was one that one of our medical students that was on an elective, I think it was a little while ago, he was able to give us this image right here. Can you guys tell me, there should be 3 signs that make you think of cholecystitis? Does anybody want to give me one or all three?
Cholecystic fluid.
Woo!
It's big.
Yep, that's another one.
The wall is thick.
Yes. Now, I will tell you that it's hard for me to know exactly if this stuff is a thick wall or pericholecystic fluid, but they both are indicative of acute cholecystitis, so I'm not sure it like matters necessarily. I think that there probably is a thickened wall, but I think that this might be fluid just because these little strandy things. Whenever I see little strands in what I suspect is a fluid collection, it makes me think more likely that it is either A, a chronic process, or B, an inflammatory process. And then I think you guys probably assume that, everybody knows this, but just in case, these are stones right here. So this is acute cholecystitis. We got either a thickened wall or pericholecystic fluid. We got a high drops of the gallbladder, and then we have stones right here. I love this image. I mean, I don't love it because it means that a patient had a problem, but this was a patient, and she appropriately labeled it as a, quote, liver mass, because it is a liver mass. Do you guys see what she's referring to? Let me put it towards the back here. Right here. This right here is a portal triad. This is probably a chunk of the gallbladder. And this is a huge, turns out, gallbladder abscess. It's a big old gallbladder abscess that was first looked at by one of our PGY1s, Jessica Atkins. She did a great job on it. Are you guys able to see that there? I've to be honest, haven't seen very many of these gallbladder abscesses before, but that's what a gallbladder abscess looks like.
Jacob, could you point out the common bile duct on some of these? I always have a hard time seeing the common bile duct and measuring it and all that stuff.
Yeah, for sure. The common bile duct is tricky. So this right here is the portal vein. This is very likely going to be the hepatic artery, and this is very likely to be the common bile duct. What you should do if you're ever looking for the common bile duct and you're not sure, I throw color flow Doppler on it, because most of the time this is going to be the artery and this is going to be the portal, the common bile duct, but about 15% of the time it's actually reversed. So instead of memorizing the hepatic arteries on one side, common bile ducts on the other, I just put color flow on it and let color flow kind of dictate which one's which. The one with flow in it is not the bile duct. Most of the time, if I can't find the common bile duct, I get further imaging if I have a high suspicion of a common bile duct stone. But if I can't see the common bile duct, or it's like equal, see how this is like equal to this about in the size, the chance of you having a common bile duct stone is probably low. And that's assuming you didn't have a really high pretest probability. And finding a good common bile duct view is something that takes a little bit of practice. I would decrease the depth if that's what I was looking at. So instead of having it all the way down here, I'd have the depth to about here, basically as shallow as I can, and still be able to see that. And then throw color flow on it. And if you can't get it, it's okay. Just try your best. Here is one that it's a bit subtle, you guys. When I first saw this, I was a little bit kind of confused about it. Now, this gallbladder wall may be a little bit thick. It wasn't mentioned or wasn't measured. You see right here, you see all these little hyperechoic little tiny things. These are actually a lot of very small kind of layering stones with shadowing in the back. Another reason why it's super important to make sure that you fan through that entire gallbladder and look really specifically at posterior acoustic shadowing posterior to that gallbladder. And my last topic, one that probably once or twice a month I see, and I've been meaning to send an email out about this because it's super important, especially if you're using your ultrasound to rule out a deep venous thrombosis in the legs. I see this. I see it labeled as rule out DVT, and I see a vein, and I see really good compression of that vein. This is a very good examination of a superficial vein. This is not a deep vein of the leg. Deep veins in the extremities always have arteries that run next to them. If you are looking for a DVT and you see a vein, but you don't see an artery right next to it, it is not a deep vein. This is very likely the greater saphenous vein, which is it's a big vein, but it is not a deep vein. Here's another one. Great compression of that vein, but there's no artery next to it, you guys. This is a superficial vein, not a deep vein. There definitely is utility in diagnosing and ruling out superficial venous thromboses, but the more important one to make sure they evaluate is the deep venous thrombosis. This is what you want to see. You want to see a vein here, and this is an artery, and then the deep artery right here. You always have the arteries next to those veins. Make sure that you, once you find that, you compress at about 1 centimeter increments. You're going to want to make sure that you can get those vein walls to touch. You always want to make sure, even if it's a little bit hard, push hard. Even if your patient's like, kind of hurts a little bit, say sorry, and then make sure that they compress. You're not looking for an actual thrombus inside the vein, which if you see one, great, but the main thing is looking for compressibility. Now here is a great ultrasound of a deep venous system. And I know that because this is the artery right here, and this right here is the vein. Now notice there's compression. We have a little bit of compression of the artery there, and I'm not seeing any compression of that vein. This is a clot. And notice that in this case, the clot itself is not very hyperechoic, actually. It's very hypoechoic. In fact, I guess I can kind of see that there's something in there. But the main thing is that I can't compress the vein. And this is one scan that one of our PAs did. This is actually a Page Rowe scan. And you can see here that we're compressing the artery, not compressing the vein. This is what a DVT looks like. When they're hypoechoic like this, just basically means that it's more likely to be a fresher clot. A more chronic clot is going to be a lot more hyperechoic. I see every once in a while some upper extremity DVT scans being done, which is great. Here's an example of performing an upper extremity examination. I like to start in the brachial and just kind of compress all the way up, just like you would for a DVT. But you can't just look at one spot. You have to at least go down to the antecubital and get all of the vein, the brachial. And while you're there, go ahead and get the cephalic and the basilic as well. And then when you are to do a complete upper extremity examination, you have to look at the internal jugular vein as well as a subclavian. Now, one thing you can do is, would be a very good idea, is to actually follow the IJ down into the brachiocephalic, into the SVC, excuse me, and the brachiocephalic. So right here, you see how we're actually angling the transducer down above the clavicle to get that brachiocephalic vein right there. Now, this vein itself, and in fact, the subclavian and the jugular vein are very hard to compress, if not impossible. Like, you shouldn't try to compress the brachiocephalic. You'll probably hurt your patient. So what you have to do with these parts of the veins themselves is you actually have to use pulse wave Doppler and color Doppler. If you see that brachiocephalic completely light up with color Doppler, great. Probably the best way to do it to make sure there's no proximal venous clots is to actually use pulse wave Doppler. This right here can be a little bit confusing, but this is actually a venous waveform. Do you remember when you're in medical school, like whatever first year, you had those venous pulsations that it was like up, down, down, up, down, down? That's what you're seeing right here. So here's one, here's another one, there's another one. This is a, maybe, I don't know if Taryn's still on, but I believe this is an E, this is an A, and that's an S wave right there. So you want to see this kind of triphasic flow, and that means that it is a venous pulsation A, and that B, there is nothing that is blocking the pressure differences in the heart from getting back into those central veins. What you don't want to see, there's color flow right there. What you don't want to see is you don't want to see this guy right here. You see how, now this is the, let's assume for all intents and purposes, this is the same vein on opposite sides or something like that, or the same vein but in two different patients. This is a normal venous waveform, meaning there's no obstruction. And this is an abnormal central vein waveform. I'm not getting any of the pressure differences from the heart to be transmitted back into those central veins. If you see this in a peripheral vein, let's say like you're looking in the forearm and you put that on a peripheral vein, this is a normal peripheral vein waveform, but an abnormal central wave venous waveform. And this right here is actually visualizing a clot in the upper extremity. This is very likely to be in the kind of more distal upper arm, these are very likely to be brachial venous clots. You see this, we're seeing this a lot in general in the literature. Like probably the most common cause is an indwelling catheter, like a PICC line, but you can see it in cancer patients as well. Basically, any risk factor for a DVT, you will give you this upper extremity DVT as well. I hope that was helpful for you all. Don't forget to check out courses.coreultrasound.com. I hope to hear from you soon, and happy scanning.